invite Dr. Ashok Verma for his presentation on predictability of corneal allograft rejection outcome, a decode using logistic regression analysis.
Members on the dais and friends, I will be covering my topic, a predictability of corneal graft rejection treatment outcome, a decode using multivariate logistic regression. There is no financial interest in any of the surgical procedures or drug used in this study. Ever since the first corneal transplant was performed, there have been significant improvement in the eye banking, in surgical techniques, and new surgical procedures have also been evolved in the form of endothelial keratoplasty. However, penetrating keratoplasty remains the most common procedure being performed, and good prognosis cases have more than 90% of the success. But high-risk corneal transplants, they have like 70% of them, they fail within 10 years due to immune rejection. Predictors of the corneal graft rejection are very well studied and they are very well known. However, the prediction of the outcome of the treatment of allograft rejection has not been evaluated. I didn't find any study in the literature. My purpose was to evaluate the predictors of the outcome of treatment after corneal graft rejections. So we had a non-randomized longitudinal study which included 51 patients, and the patients who developed corneal graft rejection at various time intervals, they were included. Patients were diagnosed clinically as graft rejection. Patients who have herpes simplex keratitis, they were also diagnosed clinically only, seeing that the KPs were present only on the host cornea, not on the rejection side. And these are the types of the surgeries performed. Corneal thickness was noted on day 1, then 1, 2, 4, 8, and 12 weeks after treatment. And this data was subjected to the statistical analysis. We didn't find any influence of the donor demographics such as age, death, inoculation interval, death preservation interval, death surgery interval, endothelial cell count on the treatment outcome in this study. After applying the logistic regression model, we found that two variables, one, the indication of the surgery and the central graft thickness at presentation, they were the significant factors, and they indicated the affected the outcome of the treatment of graft rejection. The ROC revealed that the area under curve was 91%, and it suggested that the current model is good enough to differentiate between successful and unsuccessful cases. We also tried to find out whether the percentage decrease in the thickness can tell us about the treatment outcome prediction. And this is the table here showing that if you have 5% thickness at 2 weeks or 10%, then what is the risk of, what is the percentage of outcome of these cases. And these are some of the cases. The first case is basically a patient who underwent penetrating keratoplasty for keratoconus. He had endothelial decompensation following collagen cross linking done elsewhere, and she developed the graft rejection. But the corneal thickness was very low. It was 584 at presentation, which improved significantly. So low, if you have low thickness, it improves significantly. This is the other patient. She is basically herpes simplex keratitis patient, and she has undergone bilateral corneal transplant. The other eye, right eye, is doing very well. Left eye, she had this is more than 10 years follow-up now. In 10 years, she has got the second graft rejection. This is the second episode which we have recorded in this thickness study. So the presentation, at presentation, the thickness was 785, and which decreased significantly. To conclude, I would like to say that the indication of the surgery and central graft thickness are important predictors, and percentage decrease can also be a good predictor of treatment outcome. This model is further evaluated to develop the prediction model for these cases, and this is being carried out. Thank you so much for patient hearing.
Thank you, Dr. Sharma. I think I agree to it that in this era, when we have newer procedures to deal with corneal pathologies, PK has yet not lost its relevance. But from your experience, can you tell the audience which post-operative week is the most critical after you have done a successful PK on the table? Which post-operative week, first, second, third?
So for those who are my very young colleagues, I would say that the first 2-3 weeks are very important in case we are doing PKP, because the immediate complication, post-operative complications, they can be devastating. So you have to look for your sutures. Is all the sutures are okay, exposed? Then you have to redo or do it. Look for the AC depth, it should be okay, there should not be iris this thing. Then epithelial defect is most important, especially if you have a dry eye or HSK, then look for the epithelial healing. Epithelial healing is very critical in these patients. And if you are doing a regraft, maybe that second, third, or even sometimes you are doing the fourth time also, then basically I would say that the first 6 weeks are very, very important, because these patients are already sensitized and they are going to develop graft rejection immediately. So it's better to give these patients like IV methylprednisolone, and then topical steroids, and you don't cut down the topical steroids in these patients immediately. Keep them on for a longer time and do monitor the intraocular pressure, because many of these patients, the moment you give them frequent topical steroids, they develop high intraocular pressure as well.
I agree that second and third week are the most critical post-operative weeks. What point he has already mentioned, few more points I would like to mention. Be careful, look for neovascularization, limbal vessels growing, especially in the superficial layers of the cornea. 2, have an assessment of corneal thickness. If there is an increase in corneal thickness, you may land into problem in long run. Third, take care of the endothelial integrity, so that you are taking care of this thing, that there is no rejection in times to come. The standard books mention that you have to be very watchful for 2 years, even after you have done a successful PK. Any time up to 2 years, a rejection phenomena can come up. But second and third week, look for neovascularization, especially superficial vessels growing into the graft. Corneal thickness is of utmost importance, paramount importance, I can tell you, and endothelial integrity.
Thank you, sir. Thank you so much.
So have you added, Dr.
I'm
Sharma,
sorry.
have you added any immunosuppressive agents in this high-risk graft?
We do use cyclosporine topically, or even tacrolimus ointment also, but not for the treatment of graft rejection. But
No, like
in
when
high-risk
when-
cases,
yeah,
post-operatively
when you were
we do.
doing repeat
Yeah,
keratoplasty,
Definitely.
did you used how much percentage of cyclosporin?
Cyclosporine, madam, 0.5%.
Okay, but it is usually used for
Hard.
dry eyes, not
Yes.
for preventing graft rejection.
Definitely.
For graft rejection, we have to use 2% cyclosporin. Any oral medication?
I have the problem of tolerability sometimes. So that's
Any other oral medication have you given to prevent rejection in these high-risk keratoplasties?
I have not used oral immunosuppressives for graft rejection. I rely more on topical steroids or oral steroids.
Okay, thank you so much.